Suicide is everywhere. It's at every office is where there's a kid being seen. And so for us to not attend to it puts every single one of those kids and their families at risk. And this doesn't have to be like this. Prevention is the key, and prevention starts at the first appointment. And we're all capable of managing to it. It's not as overwhelming as we think. And I think the biggest thing we can do to end a stigma around this is to talk about it.
Hi, I'm Heidi Baskfield, Executive Director of Speak Our Minds, and we are here with Dr. Jennifer Miller, who is the Service Line Director for Child and Adolescent Mental Health for San Francisco Health and UCSF Benioff Children's Health. Jennifer, we're so excited to have you with us. Thank you so much for being on this series dedicated to all things preventing youth suicide.
Well, thank you for having me. I'm glad to be here.
Before we dive into the detail, it would be so great to have you talk about what brought you into this work and why suicide prevention is such an urgent priority for you and your hospital.
What brought me into this work was I've spent a large amount of my career in mental health working with at-risk adolescents. And it has been multiple times where I have seen there was so much of it that could have been prevented. And that it's not just a singular experience for the adolescents, that the whole family, the community surrounding them is deeply involved and impacted in whichever direction that outcome goes. And to be able to do something that changes that outcome, not just from the complete risk of suicide, but also all the things that lead up to that, could really change humanity, frankly, because so much of it comes from the very beginning of when we're all learning to deal with one another and the challenges that come in with that. And if we can do better, we need to do better. So anything I can do to be a part of that solution, I'm happy to do.
Can you talk more too about the region and the communities that you serve? I think it would be interesting to hear more too about what you're seeing on the ground. What are your, what's your local context?
So we are very unique in the San Francisco Bay Area. We have over 100 different languages that are spoken regularly here, which is quite fascinating and really wonderful in a lot of ways. And it also presents challenges in others, and because it puts us in a position where we're always challenging ourselves to do something in a way that might be different than how we know to, and is still impactful and respectful of the people that we work with. We have an enormous diversity in socioeconomic status throughout the Bay Area, and we have a lot of people who come into the Bay Area that don't live in the Bay Area, but they work here. So there's a lot of influx back and forth throughout the day in terms of who might be here and what they may need. And despite not living here, people still do seek a lot of their health care here because they spend so much time. There's also a lot of resource in the Bay Area that's not as much reflected in the outlying counties. So we have a real opportunity to stretch ourselves from our application and to find new ways to do things that are valuable for the people that are here. It also presents a lot of complication in how we have to go about doing things, because it's important to us to respect the mission that we hold, which is that we are here for everyone at all times. And we intend to always show that to people as they come through our doors so that they feel welcomed and accepted and seen. And to do that for the high amount of diversity that we serve does mean an awful lot of flexibility on our part on a regular basis. So it has been, of all the places I think I've been as a therapist and as a healthcare administrator, it is one of the most challenging from that perspective. It's also been incredible around the amount of growth I've seen of everyone around me responding to things. And particularly what's going on in the political environment, our hospital system has responded with a lot of valor to that and is very clearly still holding strong to the mission that we are here for the people we take care of. And that is our number one priority at all times.
That's amazing. And when you think about so much of the work in preventing youth suicide, it's the ability to respond to the individual needs of all that come through your doors. Can you talk about how the incredible diversity in your community has informed even the early stages of planning for how you were going to go about screening for suicide risk? How has that context informed where you've been so far?
Well, one of the things that we have to think about in particular is when it comes to our community that has immigrant background and what that means for them when they come into the hospital. Even prior to the last, we'll say 8 years, that's always been something that we had to be mindful of. So we didn't instill fear in people or give them any reason to think we were going to do something that was going to cause a disruption to their family system. And so one of the pieces of suicide screening is that you ask the parents or the caregivers to leave the room, that can be very threatening for someone who doesn't understand why you're doing it and also what you're going to do. So, how to navigate that in a way that is very clear that we're maintaining respect for the family system and that we're not going to do anything that's going to put them at risk or have a consequence that they did not sign up for. So, we have made a lot of effort on that. Part of it is always making sure that we have people who can speak in the language of the patient or family that's presenting so that they have very clear communication. It's frightening enough to come into the ED. And then an added layer of we're going to talk about something like suicide, which for your average person is not a comfortable subject. And so bringing that up and then culturally, whether that's even something that's acceptable to speak about, there's a lot that we have to think about when we go through that. So we do a lot of education. Our initial screening in our EDs is done through our nurses in triage or the bedside nurse if the screening can't be done until the patient's been roomed. In the hospital on the inpatient floors, it's still done by nursing. And they do a wonderful job thinking through all of that and being mindful of the impact. And we re-educate continually to make sure that we're keeping people as up to date as possible on how to do something. And if they don't know, you always can ask.
How do you continue to create a culture internally where your staff can feel safe to learn from their mistakes in that way? I mean, when you start talking about we're implementing practices to prevent suicide, inherently that sort of, brings a bit of a heart palpitation in people, right? Like there's a different feeling about that, both from how they're going to potentially approach parents and just sort of making sure that they're being as responsive as possible. So what is it about the way that you approach these conversations with your nursing team and those running the screeners that allows them to feel comfortable? Like this is a learning environment and we're going to continue to make mistakes, learn from those mistakes and improve.
Well, we recognize how lucky we are to have an entire group of nurses, both inpatient and outpatient, that are truly dedicated to this work. It's not often where in mental health we're not having to explain the why of something. And so while there's a part of that, the type of nurses that come to work at Benny Hill Children's Hospitals, they choose this for a reason. They wanted to work within the populations we serve. And so it wasn't really that hard to have that conversation with them. And also they are advocates, genuine advocates for what they think needs to be done and how it should be done. So if there's something they feel like wasn't correct or it could have been done differently in order to support them doing their job better, they always advocate for it. And that culture is very strong. And the other piece that we make very clear is that if anything feels really off, behavioral health is always there. So we have a team embedded in the emergency departments and in the inpatient units that will step up. And so if the nurses detect something that they feel like they're unsure about, they know that we're there to help. And that's been the relationship that we've had for a long time.
That's amazing. So let's start getting a little more technical and start talking more about the screening tool itself. In your world, there continues to be conversations about which screening tool is the more effective in this space. Is it the ASQ? Is it the Columbia? How are we making those decisions? For people having those similar discussions, can you just share how you went about making this decision and what you decided and why?
So we chose the ASQ because of how quick it was. And we do universal screening in our emergency departments. And so we wanted to make sure it was something that could be done quickly and effectively. And that has been really effective across the board. We do it in both our San Francisco and our Oakland emergency departments. And we have a very, very high screening rate. On average, we're between 95 and 100% for all patients aged 10 and above. And I think a lot of that has to do with how quick the screening tool was. I think the Columbia is effective. So it's not that I don't think so. And just for clarification, we use the Columbia with the safety for the risk assessment for any patient who screens as an acute positive or a non-acute positive. So we still use that tool as a follow-up for the longer risk assessment and the safety planning, but for just the initial screening universally, the ASQ has met our needs perfectly.
And when you think about that, again, you mentioned the universal screening, specific settings like your emergency department. How much did the setting itself inform that choice?
The ED was where we started. And so finding something that was going to be as time efficient as possible was what we wanted to do, because we understand that the clock runs in the ED all the time. And so making sure we did things that did not slow it down. And behavioral health work in the ED, this is the dance that we are always doing, is trying to figure out how to do our jobs that tend to take a little longer and marry that into the speed and efficiency of an emergency department. And the ASQ matched really nicely.
Talk about when you were first in the beginning of this and you were really integrating this practice with the ED staff. What were those discussions like? What were the challenges that you were initially facing? And what were the training protocols that you had to create to make sure that you were identifying the appropriate people to do the screeners and keep updating everybody on how to use that tool and the follow-up that comes from its use?
Well, when it very first was implemented, I was not yet with UCSF. So I came in a little bit after that. But I can tell you from what I've been told there and then what we've done as we continue to go through process improvement with it. So essentially, the first worry with something like this was how much work would it create? Then what would that mean overall? So making sure that we talked through exactly what the timing was going to take for this to happen, who it really belonged to. Given the nature of the screening, nursing was the ideal group to do it because it fit in very nicely with the initial triage questioning. And then, like I said, there's times when it needs to go into the rooming portion of it. But for the most part, that really fit in nicely there. And then anything that came out of that required longer intervention would fall to either the behavioral health teams or medical social work. So that was where the conversation extended, was what to do for the risk assessment and the safety planning and who should do what. For the acute population, in general, the conversations were this should be a behavioral health response. They need to come in and do the risk assessment because they also have the authority to write the 72-hour hold if necessary. And social work took the bulk of all of the non-acute assessments, but that's the bulk of what comes out of ASQ screening is non-acute more than acute. And so they run the same protocols that behavioral health does. They will also do the Columbia with the safety. And then in the event that it became clear that the patient really was acute instead of non-acute, they would escalate it back to behavioral health. So essentially it wasn't too terribly hard to figure out who went where. It was more a matter of how long would it take and what was the play that we needed to follow and how to communicate that with one another to make sure it happened. One of the barriers that we ran into, and in our process improvement have revisited it at times, is making sure that as the patient does screen as acute, not so much acute, that tends to be taken care of without fail. The non-acute, we make sure they get that risk assessment before they leave. They came in for something that was not an identified behavioral health concern, and there's any break in communication and social work isn't notified, that can happen. That was a hole we had identified. And we've been continuing to make sure that we're staying on top of that because we want our post-screening assessments to be at 100%. Yeah. So how to make sure that happens continuously. And the biggest issue we run into really is staffing barriers to make sure that we have the ability to get those risk assessments completed.
Well, and I'm not surprised to hear that. And when you also talk about your amazing adherence rates, what I hear you talking about is what has served as like a key to your success is the clarity in when there becomes a behavioral health provider handoff. Like at what point does that happen such that staff can feel comfortable in taking things to a point at which then it exceeds perhaps their level of expertise, but there's another clear provider partner that they knew who to hand the care off to. Am I saying that right?
Oh, absolutely. Yep. Making sure that our workflows are very clear and clean so that people don't have to wonder what to do. And with something like this, like we talked before, suicide is scary. And so whenever you're unsure about a step in that process, it just elevates it even further into the cloud of anxiety that can come from it. So making sure that we have things very clean. We have a suicide task force that meets monthly. The overall task force to ensure that we're following our protocols. And then if we're noticing any dip in our adherence rates, that we're attending to that and to the why. And then we have subcommittees that get underneath that related to workflow and policy. So we have a lot of effort and energy, multidisciplinary committees that work towards making sure that we're staying on top of this and that we're moving forward with any new information that comes to us around what might be a different evidence-based way to approach something. So, and this again, has been such an incredible partnership between the physician leadership and nursing leadership and social work for us to all come together and obviously with behavioral health to always be looking at this. We're really lucky to have such a large amount of people that are dedicated to this ongoing.
Yeah, it's really incredible. You know, we talked too about like there's this whole body of work that needs to be stood up and supported continuously for the effective screening. And then you've already alluded to what happens after the screening, right? And the handoff process. So from the work that you've done to date and the amount of success that you've had in this space, what are the best ways to track follow-up assessments once the patient has been screened? Just lay that out for some of our colleagues and those interested in standing up similar models. Like once you get through that screening, what are those key pieces that entities need to have in place to effectively manage what comes up in the screening?
Well, this is one of the reasons that we chose to go with the CSSRS and the safety, because it allowed us to put that into a flow sheet so that we could track stratified risk following the screening and that we can continue to pull the data forward if we need to so that we can see if there's any change. So particularly for patients who come into the emergency departments on a regular basis, if they are going to screen non-acute positive, they will for a certain length of time given the parameters of that screener. We don't want this to become a painful process. We still want it to be accurate. So we will pull the Columbia forward from the last time and their safety plan from the last time. And we can do that because of the design of that tool. And that has been really helpful for us to be able to confirm with the patients rather than reassess every time. And it's much faster and it still maintains the accuracy and validity of the tool for us to do it. So that has worked out really nicely. And our medical social work team in Oakland in particular has talked about how much they appreciate that approach because we don't do it just in the ED. We also do this in our inpatient units. And so it's one of the pieces that we use when a patient is admitted, and sometimes they are being admitted for something post-suicide related, like intentional ingestion or something, or in other times it's a patient being admitted for something completely unrelated to behavioral health, and they still screen positive in a way that requires intervention. So we follow up. It's just far less painful for them if we're pulling things forward and revisiting something versus redoing it all over again. If there's one complaint I've heard from patients, both as a therapist and otherwise, is I don't want to tell my story again and again. So finding a way to solve that for people, that tool has worked really well for us to do that. And it also, because it can be put into that type of format, allows it to do data tracking in a way that's cleaner. So we can use that, which is something that we're trying very hard to do, is do more data-informed decision-making in behavioral health. And so this lends itself to that.
Yeah, and inherently will lead to improved quality outcomes that are better for everybody. When you get into this work too, Jennifer, and that continues to evolve, one thing that we've heard from partners across the country is we're nervous to start a universal screening protocol without knowing if we have the capacity to handle all the need that gets identified as a result of those screenings. And there are many hospitals that are already struggling with stuck patients, right? So you all have taken a really unique approach with respect to your crisis response and your bridge clinic. Can you just describe that so that others understand one of the potential options out there and how that's made a difference for you and the population that you're serving?
Sure. We're very excited about our crisis response and bridge clinic, which we call the CRVC. So this was born out of what was originally called aftercare for our behavioral emergency response team. And what we did was we took that idea and expanded upon it. So one of the things that it can solve for is patients who come into our emergency department who are at around maybe a medium risk, don't quite meet the need for the hold, could if we didn't have a safer option for them. And oftentimes we're finding is that people who don't have an already established group of care to discharge that feels very risky. So the crisis response from Bridge Clinic takes the patient. They immediately can take them and hold them for 12 weeks in weekly therapy. All of the patients, the therapists are trained in trauma-focused CBT, along with other evidence-based practices like CBT and DBT. And we also have a dedicated case manager for that whole clinic so that any other resources in addition to just the therapy that are necessary, she will help go through the community and work with the family and the patient to get them. If we figure out within the first 2 to 4 weeks that longer term therapy is going to be needed, that also becomes part of what they do. They start working to find a longer term placement, and they don't hand off the patient and family until there's a warm handoff available to the next level of care. So this can keep people from having to go into the hospital unnecessarily, to board longer in the ED, because we have this team that's dedicated. We're very, very, I don't know if religious is the word I want to use particularly, but we're very focused on making sure that we don't go beyond those 12 weeks unless necessary so that we can continue to maintain access. Because that was one piece that was a worry for us. If you set something up like this demand that lives out there is just going to flood the clinic. And so far, we've been able to do just fine. And keeping to the 12 weeks allows us the right amount of turnover in order to keep the caseload open, so that people can come in. And sometimes they don't even use the whole 12 weeks. Sometimes it's less, sometimes it's slightly more. And other times we're, as I said, transferring. We also have a psychiatric nurse practitioner as a part so that we can do medication management as well as a part of this. So we try really hard to be full service so that anybody that is going to be able to can be seen within 24 to 72 hours of being in the emergency department. We also will respond in the event that there are any patients that show up in any of our outpatient clinics that screen positive for suicide risk or heightened mental health concerns. And our crisis response team will go to those clinics and do an assessment there. If it's pointful, we'll give them an appointment within the CRBC, and then they will take that patient and hold them in the same way for anybody else. So it's been really productive. And it's been lovely to see the impact we hope we would see of people getting service right away and less boarding in that sense. Boarding in the ED is really nobody's idea of a good time, and it makes the situation 1,000 times harder. That's not a hard statistic, but it's just my emotional one. So it's really anything that we can do to alleviate that and open up access, because that is the biggest challenge we see, period, in the community. And as I said in the beginning, that's a part of the total continuum of preventing suicide, is that we have access to the services people need when they need them. The longer there's a delay, the more people get sick, essentially.
Yep.
So with any medical issue, that's the case. So making sure that we have what they need before it gets to a point of total severity is the idea. So that's what the clinic will do. And the Bridge Clinic part has been lovely to watch be productive.
Well, I'll just tell you, Jennifer, like if there's one thing that comes from our time together today, I hope there is a huge uptick in a lot of your colleagues across the country thinking about how to duplicate this model and really thinking about the efficacy of it and how big of a difference it makes for these kids and these families. It's just like nothing but huge applause for you and your team for getting this up and having it work. This then leads me to the next piece, and that is really how you're treating parents as partners and how you're better equipping them and what you're training parents to do in this space. So can you just share a little bit about the innovative approach you're taking in that space with the training you're providing your parents?
So we have a brilliant psychologist that is UCSF faculty who has designed a DBT program that's a 4-session program. Sabrina Duro, wonderful, wonderful human being that put this together out of recognition that, again, wait lists are long. And particularly when it comes to our DBT, our certified DBT program in the West Bay in San Francisco. And oftentimes the requirements for people to be in those programs is that they had a suicide attempt or that they had been hospitalized for being at imminent risk of one. And so when there's a wait list for something of that acuity or of a population with that acuity, what do we do in the interim? And so she created this brilliant training program for parents to be able to learn the skills to support their kids while they're awaiting placement. And it has been received really well. And she's done it multiple times. And we're going to be bringing it hopefully into the East Bay sooner rather than later. It's this kind of innovation that we need going forward, because the challenge that we have oftentimes in behavioral health is that we have thought this is how we do things and we don't deviate from that approach. And we really will benefit from deviating from that approach because we have a lot of beautiful skills that can be used in a lot of different ways that are evidence-based and appropriate and make sense to the people we actually are here to serve. So getting outside of our sort of rigid box of doing things. And this is what she did with that. And it was really effective and has continued to be. I look forward to more of that, essentially.
Yeah, for sure. And I think, as a mom with kids, from my own parental experience, right, like wearing that hat, I want to be part of the solution. I don't want to have to hand everything off to care teams all the time, right? Like I want to have those resources. I want to be empowered to be in the mix and to be part of the solution that keeps my kids from coming in and needing higher levels of care. I mean, it's better too, right? So like these unique and innovative approaches, all that we can do to get the word out and talk about, let's get these expanded. Let's have more of our partners engaging in this kind of work is only going to better serve youth in this country. So as we wrap things up, because you and I can talk about this all day, every day. And I'll look forward to other opportunities to keep talking about these kinds of things with you. But Jennifer, if there's one thing you want to tell hospital leaders throughout the country when it comes to youth suicide prevention efforts, what would it be? What do you want them to know?
I've never been a quick speaker, so this is a challenge. I think what I would say is it's everywhere. It's at every office is where there's a kid being seen. And so for us to not attend to it puts every single one of those kids and their families at risk. And this doesn't have to be like this. Prevention is the key, and prevention starts at the first appointment. And we're all capable of managing to it. It's not as overwhelming as we think. And I think the biggest thing we can do to end a stigma around this is to talk about it.
I think that's wonderful advice. So Dr. Jennifer Miller, thanks to you your incredible team at UCSF Benioff and San Francisco Health. And we just want to say what an incredible asset you all are in this effort. And we're so thankful for the work that you have done and continue to do in preventing youth suicide. So thanks for being with us today. And we'll look forward to keep talking and checking in on how you're expanding and how things are going.
Thank you. It was an absolute joy for me.
I appreciate it. Thank you.